For women with a heart condition, and even those without, pregnancy can bring unique challenges. Dr. Lauren Latzinger joins us to explain why cardio-obstetrics is a must. What is cardio-obstetrics?
So cardio-obstetrics is a field of cardiology that has really arisen out of an observed increase in maternal mortality or maternal deaths during pregnancy or within the first year postpartum. And we've actually seen in the last 20 years a rise in maternal mortality in the United States from around 10 deaths per 100,000 live births to up to 17 really in the last few times, and the numbers are continuing to rise.
And is it all related to heart problems?
The most common cause of death in women during pregnancy or the postpartum period is actually due to cardiovascular causes.
Does the heart change during pregnancy?
It does. So there are a number of hemodynamic changes that happen to any woman who's pregnant, whether or not they have heart disease. And it's including increased plasma volume, which then increases your cardiac output. And I realize some of this is a little bit technical, but you just have more fluid on board, so you have more stretch in the heart. Your heart rate increases by about 10 to 20 beats per minute. Your blood pressure may go down a little bit. And in a normal, healthy person, those changes are really tolerated just fine. But in someone who may have underlying heart disease or at risk for heart disease, that can sometimes cause problems.
Is the extra weight a problem or hormones a problem?
Hormones are, I think, a little bit less understood, sort of the physiology, but we do know hormones play a role in things like increasing your risk of clotting during pregnancy. They also can affect tissues. So in women who have things like aortopathies, like Marfan syndrome or Loeys Dietz, that actually is a risky time. And we think some of that is due to hormonal changes in pregnancy.
So we're talking about women who don't have any history of heart disease. What are symptoms or signs that you would look for or that even the patient would notice?
And there are certain things, and I will say that with women who don't have underlying heart disease, the risk of cardiac events is low, but not nothing. And so one of the most common things that sort of fits into that cardiovascular disease under that umbrella are things like hypertensive disorders of pregnancy, like preeclampsia or gestational hypertension. And symptoms of that may be nothing, and you just notice you have high blood pressure, but you may have headaches, vision changes, shortness of breath, difficulty breathing, swelling. And for things that are more or less common, like spontaneous coronary artery dissection or SCAD or peripartum cardiomyopathy, which is a specific version of heart failure that happens during pregnancy or the postpartum period. It might be shortness of breath, it might be swelling in the leg, shortness of breath lying flat. And that can be really tricky because, as anyone who's ever been pregnant knows, in your third trimester, shortness of breath, swelling in the legs, shortness of breath lying flat are very common symptoms that normal people have in the third trimester of pregnancy. And so it can sometimes be difficult to tease out. But certainly any symptoms that are new or severe or very significant are worth contacting a doctor for.
And you said everyone will have some of those symptoms. Is that why it's important for people to see their physician on a regular basis when they're pregnant?
Yes, and most women who are pregnant will just see their obstetrician. But women who have underlying heart disease to begin with, it's also important that their cardiologist is an important part of their pregnancy care team during pregnancy and the postpartum period.
There are people that have heart conditions that are afraid to be pregnant, who are afraid to get pregnant. What do you tell some of those people?
I think the biggest thing that women with heart conditions need to know is that the first step would be to get a preconception counseling visit. So meet with somebody who has expertise in cardio-obstetrics to decide truly what is my risk. And so I think that can be very reassuring to patients who may not actually have a significant increase in risk during pregnancy. But if they do have a significant risk, that's also something that patients need to hear. And when we have those visits, when I do those visits, we talk a lot about, what's the underlying issue? How do I expect pregnancy to change that? And we can really sort of help try to predict what the risk might be. And a lot of times it isn't much. And so that can be very reassuring.
So if you do have an underlying heart condition, it's important to see a specialist, like a specialist at Ohio State.
Yes, absolutely. And I think some general cardiologists are comfortable with it. A lot of them aren't. And so even people who don't have sort of specific pregnancy-related heart disease, even if it's just PVCs or palpitations, but certainly women with coronary disease or heart failure or rhythm problems, we're happy to see them at any time for preconception counseling if they become pregnant. That's really what our area of expertise, and that's what we do, and we love seeing those patients.
So as a woman who does have this pre-existing heart condition, what kind of challenges does pregnancy represent?
So it really depends on what your pre-existing condition is. that extra volume load in pregnancy, the extra cardiac output, the higher heart rate, that can be really significant for women who have a cardiomyopathy or weak heart muscle. It can cause increased shortness of breath, increased risk of pulmonary edema or fluid on the lungs. It can cause valve problems. So if you have had a valve replacement or have a leaky valve or a narrow valve, that extra volume can cause worsening of that valve problem. Women who have maybe a need to be on anticoagulation, so with like warfarin or Lovenox, if they have a mechanical valve, certainly risk of clotting versus bleeding during pregnancy can play in pretty significantly.
Are there different symptoms for women who already have heart disease? Or I suppose it might depend on what their heart issue is.
You know, I think we counsel patients who have pre-existing heart disease on symptoms they can keep an eye out for. I think it's a little more challenging if you have nothing and all of a sudden you have new symptoms. And heart symptoms, you know, are heart symptoms whether you're pregnant or not. And so I think the problem in a young, healthy woman of childbearing age is that oftentimes they're not expected to have these heart problems. And so another thing we like to do in cardio-obstetrics is educate the general public on, yeah, you may be young, you may be healthy, but you can develop things like clots in your lungs with increased frequency in pregnancy, or heart failure in pregnancy, or heart attacks, specific types of heart attacks in pregnancy that really should be taken seriously during the pregnancy and the postpartum period.
We've all been talking about the mother, but how does the fetus affected by these?
Luckily, the fetus is generally pretty resilient, but certainly they can be affected by cardiovascular diseases in mom. And so the most common things that we would see would be fetal growth restriction, preterm labor sometimes in women who have significant heart diseases. There are certain medications that you should not be on when you're pregnant because we know they cause birth defects. And so those are important things that need to be addressed prior to pregnancy or early in pregnancy in women who have pre-existing heart conditions who might be on medications. But I would say by and large, they're not, invincible, but they're pretty resilient.
Do they need any extra monitoring or just a yes?
Yeah. So women in pregnancy often do need extra monitoring, and it again kind of depends on what you have going on. But the types of monitoring we'll do during pregnancy might be heart monitors to look for rhythm issues. We might do more frequent echocardiograms or ultrasounds of the heart to monitor valve problems, heart failure, aortic size. In the hospital, sometimes we'll have patients on heart monitors when they deliver, which is that's something that can be done at Ohio State and keeping mom and baby together. We might need the woman to see another specialist during pregnancy if we feel like there's something else that needs attention, such as a surgeon or an interventional cardiologist or an electrophysiologist. And so we keep a pretty close eye on our moms just because we have two people to get through pregnancy and the postpartum period safely. And so there does tend to be a lot more monitoring during that period that might not be at the baseline for the person who has pre-existing heart disease.
You named all these other cardio specialists. Is that why it's important for someone who already knows they have a pre-existing heart condition to see a specialist?
Well, I think the best thing about our cardio-obstetrics program at Ohio State is that it's a cardio-obstetrics program. So it's not just me as a cardio-obstetrics specialist participating, in the care of these patients in a vacuum. We have a really great multidisciplinary team at Ohio State that includes our general obstetricians, our maternal fetal medicine specialist, our cardiac and OB anesthesiologist, our cardio-obstetric cardiologist, nursing from both cardiology and obstetric floors. And we all meet once a month and discuss all of our patients who are pregnant with cardiac disease. And we're able to come up with a very individualized plan with what monitoring needs to be done, what testing needs to be done to help get these women and their babies through pregnancy and delivery safely. And so it's a really, really nice multidisciplinary group that works together.
What do you think about the risk factor? Does that depend when a woman comes to you what her underlying disease is in heart?
Yeah, and there certainly anyone who has underlying heart disease is going to have a little bit higher risk than someone who doesn't. But that risk is very individualized and it's very dependent on what they have. And there's certain conditions that we think maybe are even prohibitively high risk for women to get pregnant, but there are certainly my patients who have congenital heart disease, often when they were younger, we're told they should never get pregnant. And now we're learning more and we have more research and we find out that's not at all the case. And so it really is, if you've been told you can't get pregnant, I would say it's really important to just consult with somebody in cardio-obstetrics to realize if that's actually true and to have just a real conversation about what is that risk. Everyone has different risk tolerance. And so might feel too risky for one person is not risky for another person. But yeah, risk is very individualized.
And I think that it's interesting that you said, people, 10, 20 years ago said that you shouldn't have a child. At this point, you're saying to everyone, find out, not just say, I can't.
A lot has changed in the last several decades. And I think we have gotten women, even with very, very high risk, through pregnancy safely. And I think that's the benefit of working with a multidisciplinary team. You have so many eyes looking at it and so many people conversing and trying to come up with a safe plan that really I wouldn't say it's safe for everyone, but there is a lot of hope, and a lot of people who were told they can't get pregnant can absolutely get through pregnancy safely.
How often do you see these type of patients? Is there a number that you can put on the population of women?
Yeah, so our cardio-obstetrics program in the last couple of years has had about 400 women who we've followed during pregnancy, and that really is anything from as simple as, PVCs or extra beats from the bottom part of the heart to patients who have severe heart failure, and even in the last several years, patients who have had a heart transplant. And so we've gotten a lot of women with a lot of high-risk stuff through pregnancy, not without a lot of gray hairs that I have developed, because it certainly can be a stressful time for both mom and family and the care team. But we see, I would say, probably on average about 200 women a year in our cardio-obstetrics program.
So how does that feel when you get a mom and a baby successfully through that process?
It feels amazing. And I think, again, a lot of people focus on getting mom and baby through the delivery. And I think we all breathe a sigh of relief when mom and baby are through the delivery. But the other thing that I always emphasize to my patients is that we don't stop worrying about it at that point, because we do know that many complications related to pregnancy can actually happen postpartum. So even in the next 6 to 12 months postpartum, we see cardiac events that really can be life-threatening. And so it's that monitoring period doesn't really stop until a year postpartum.
Is the monitoring with a gynecologist? Is it with their OB? Is it with a cardiologist? Who monitors for that year?
Great question. I think this is an area where in cardio-obstetrics and in cardiology in general, we have a great opportunity and room for improvement. In general, women will see their OB about 6 weeks postpartum. And especially for things like hypertensive disorders of pregnancy, preeclampsia, that's where it ends. And a lot of these women are young and maybe don't have primary care doctors. And so we really have a call to action, I think, in general in the cardio-obstetrics community for things like primary care doctors, family medicine doctors to really help engage with these women, to help monitor in the postpartum period for even just things that pop up. Like if a woman pops up and has preeclampsia symptoms 2 weeks postpartum and they can't get in with their OB, how do they get access to care? Or if they're developing shortness of breath 4 months postpartum and they've been discharged from their obstetrician, who's going to see them? And if they're not connected to a primary care or a cardiologist already, that can really lead to a delay in care, which really can lead to problems and potentially very serious problems if they're not dealt with soon. And so I think we would love to have more engagement from the primary care community, cardiology in general. I think there's a lot of room for improvement there.
So I think it's interesting that you talked about up to a year. So women should know, even if they've never had heart disease before, that a follow-up for an entire year is really what you look at as a physician for a woman's health.
Well, I think if you're doing fine, there's not really reasons to follow up. I think it's always important to have a medical professional that you can connect with if you have a problem, because most women go through the postpartum period and do just fine and have no issues. But if you are a woman who develops something new symptom that's weird to you, if you're noticing 3 months postpartum, you have swelling in your legs, or you were feeling fine and now you're very short of breath going up the stairs, how do you connect with someone? How do you get that evaluated? And so it's not that every woman who has a baby needs to see a doctor regularly for the year postpartum, but if you're having symptoms that are new or different from you, you certainly need to have them evaluated. And so a lot of that is then having access to care, educating people who are going to be seeing these people on that year, that there is still risk there for pregnancy-related problems, and then helping facilitate evaluation.
I know research is a big factor. What about the research at Ohio State in this area?
Yeah, so research, pregnant women from a research standpoint are considered a vulnerable population. And so it doesn't mean that we can't study them. It just means that we have to take extra steps to make sure that they're protected in whatever research we're doing. And as such, a lot of the research that involves pregnancy or pregnant women tends to be observational, so less randomized controlled trials and more we're just going to observe how things are going, or even retrospective. So we'll look back and say, okay, we followed this many women with this condition over a period of time. How did they do? And so we do have a lot of research going on here. The maternal fetal medicine group is doing a lot of research in all kinds of cardiovascular conditions, and we're looking at a lot of observational studies with our cardio-obstetrics group.
I'm going to go back to something that we said earlier when it was a woman who wouldn't have heart disease initially, but then starts to get some symptoms. Do they have heart disease after they deliver, or do those symptoms go away when they deliver?
If they develop heart disease in pregnancy, if they develop heart disease, it's heart disease. And so if the symptoms are related to heart disease, that is something that may recur, and I'm trying to sort of figure out specifically.
Like preeclampsia, that goes away and it goes away, right?
So preeclampsia, for something like preeclampsia, number one, that can actually develop postpartum, but if you have preeclampsia once, you're at increased risk for having it again. Women who have preeclampsia, we know, are at increased risk for persistent hypertension or developing chronic hypertension in the long term. We know that women who have preeclampsia, gestational hypertension, gestational diabetes are at increased risk for cardiovascular disease down the line, so even decades later, so they're at increased risk for heart disease. And that's another important education piece for our women who develop some of these cardiovascular conditions during pregnancy is knowing, hey, you have this extra risk factor. Your blood pressure may go back to fine, and you may forget about it. But in 10, 20 years, that may be an additional risk factor that your doctors need to take into account when counseling you on other conditions you may develop later in life.
Okay, so we talked about women who are healthy, and then they develop some of these. What about the symptoms that we were talking about?
So women who are previously healthy can have new cardiovascular problems during pregnancy. One of the most common is preeclampsia, which is considered a hypertensive disorder of pregnancy, meaning it's a problem during pregnancy where your blood pressure is high. That can be an OB emergency. Symptoms with that can be nothing and just noticing a high blood pressure, but it can be headaches, vision changes, increasing shortness of breath. That is one of the more common, I would say, sort of cardiovascular conditions that we see in pregnancy, although really it's more of an obstetric thing rather than a cardiovascular thing. And that happens in 1 in 25 women. Some more serious but rarer, I wouldn't say more serious, but rare cardiovascular specific complications are things like spontaneous coronary artery dissection, which is where the arteries of the heart actually split and can cause a heart attack. And symptoms with that are really like heart attack symptoms. And so it might be chest pain, pressure, heaviness. It might be acute onset shortness of breath. And just like in general, we know that women with chest pain often get ignored more than men do and are not evaluated. But I would tell you that pregnant women who come in with chest pain are also often not taken seriously because people just don't think that this young, healthy woman in their 20s or 30s would be at risk for having a heart attack. So I always encourage my patients, to advocate for themselves, but also try to educate healthcare providers to not ignore chest pain in a pregnant woman. And then and I would say that one occurs, it's very rare. It's about 1 in, I think, 10,000 pregnancies. I'm gonna have to, hold on. So spontaneous coronary artery dissection happens in very rarely 1 in 20 to 30,000 pregnancies. So rare, but still something you need to think about in a pregnant woman with chest pain. And then another rare but serious complication that can happen during pregnancy is something called peripartum cardiomyopathy, which is a specific type of heart failure that is related to pregnancy. And that's, again, rare, happens about in 1 in 4 to 10,000 pregnancies in the United States, but more common in some other areas of the world.
We're talking about so many different things, and I'm wondering, are there signs in some women that is there a way to tell who might develop these types of issues? Does age, weight, what you eat, lifestyle, anything?
Yeah, and there's certainly, we know that things like spontaneous coronary artery dissection are associated with things like fibromuscular dysplasia, or can be more common in women with autoimmune problems. But a lot of it's vague. Like a lot of times you don't identify a specific risk factor. Peripartum cardiomyopathy is more common and a lot of things are more common in women who have multiple gestation pregnancies, so twin pregnancies, triplet pregnancies. A lot of these things that can develop we know are more common, but there aren't any very specific, I don't want all women with twin pregnancies to think, oh man, I'm really at risk for this. There's not very strong really strong predictors for any of these conditions. And the biggest part is that they're just very rare, which is great. You know, they don't happen often. And when they do, you try to associate them with something, but oftentimes you don't get a great, clear answer.
Just telling pregnant women, it could be up to a year that you experience these things. Don't be afraid to tell a physician, I was pregnant, you know?
Yeah, I think when women come in with symptoms related to heart disease, whether that's chest pain or shortness of breath, a lot of times they're otherwise young and healthy. And so the scary things are rare. And so they're not necessarily even in the top 10 on somebody's list of things that might be going on. I think knowing if a woman has been pregnant within the last year helps raise some of the things that might be very rare up a little bit higher on the list. And so I think it's always important for a woman who's been pregnant in the last year, who's being evaluated by her primary care or in the emergency department, to let the care team know, hey, I was pregnant. And does that play a role in anything that you could be thinking about today?